So good morning or good evening. We are here to discuss a new desktop helper and a new initiative from IPCRG that has to do with COPD and mental health, and has the main outcome to discuss about the initiatives that we should all take in primary care. So I would like to welcome my colleagues here for this nice discussion. I hope it will be nice. Let me start from the way I see them in the screen to introduce yourself. So Björn, would you like to introduce yourself? Just to say that my name is Ioanna Tsiligianni. I'm an associate professor in general practice and public health in the University of Crete, and the past president of the International Primary Care Respiratory Group. So Björn, the floor is yours.
Oh, hello. My name is Björn Ställberg. I'm a GP working in mid-Sweden and researcher at the University of Uppsala and associate professor in primary care there.
Good, thank you, Björn. Catalina.
Hi, I'm Catalina Panaitescu, a GP working in Bucharest, Romania. I'm also one of the two coordinators of the Romanian Primary Care Respiratory Group, Respiro, which is affiliated to the International Primary Care Respiratory Group.
Good. Stephanie?
Hi, I'm Steph Taylor. I work at Barcelona Medical School, where I'm a professor in public health and primary care. I'm duly accredited in primary care and in public health, and I have a strong research interest in applied health research for people with COPD, particularly psychological conditions.
Fantastic. Cláudia?
Hi, good morning. My name is Cláudia Vicente. I'm a GP in Portugal, and I'm actually the responsible for GRESP, the member in Portugal of IPCRG.
So Steph, would you like to tell us why do you think it's important to deal with the mental health in patients with COPD? What is the value of that?
Thank you, Ioanna. Like all long-term conditions, anxiety and depression are very common comorbidities. So we know that it's quite common for people to have significant anxiety and depression on top of all the symptoms from their COPD. And obviously, as physicians and general practitioners, we're caring about the whole patient. And I think it's very important to have a sort of holistic approach when we're thinking about COPD. And there's evidence from a study done by Guthrie not very long ago in the UK, which looked at COPD, included looking at people having reviews with the practice nurses and doctors, that when people were trying to raise concerns about their mental well-being, the physicians and the nurses were sort of ignoring it and I think that's because they were focused on doing the things for the QOF points and the standard review, and they weren't engaging with the whole patient. And that was really rather sad. And they interviewed patients afterwards about how they felt about that, and patients realized it, and they were sort of trained almost in those interviews after that sort of encounters to not raise those psychological issues and feelings of thoughts and feelings with their doctors and nurses, because the doctors and nurses weren't responding to them. And clearly it's very important to address the whole patient, because how you think, how you feel, how you respond is all interrelated, and it's interrelated with symptoms and your experience of symptoms and your quality of life, how you're coping, how you're living with your long-term condition.
Okay, and I suppose it is also important because if a patient with COPD has also mental health disorders, this leads to more exacerbations, lower quality of life, and worst outcomes in general. So there is a clear need, I suppose, to do something about that. And in the literature, it's not very highly cited, so we don't have huge publications, many publications on that topic, and that's why IPCRG decided to focus on that. And also, so Björn, 30% of patients with COPD have depression and up to 70% have anxiety. So what's your view on that? Do you think that the primary care physicians in Sweden know that, take that in consideration? Do they make something different? Do they assess? I just want you to give the landscape of Sweden.
I think in Sweden, one problem when you see the COPD patients, that you're so focused on exacerbation, on lung function, spirometry, and you don't ask about, are you depressed, do you have anxiety, which could be a reason for also for exacerbation. So I think we miss this, and I think many of the GPs, they don't know that depression, so many of the COPD patients are depressed, and this is a problem. They have impact on quality of life and exacerbation. So I think we can do much better in Sweden. And in Sweden, you know, we work in group practices, and we have resources in our practice with for psychological treatment and CBT and so on. So we can do better.
And you have all these resources in the primary care settings?
Yes, yes. In our practice, I think we have 3 psychologists working in our practice with CBT and other things, but it's not common that we refer COPD patients for that, even if we have the resources, because we don't ask the patient about this, and we don't use questionnaires.
Okay.
For this reason. But if you primarily have an appointment for depression, not a patient with COPD, other patients, young patients, older patients, you make a referral within the practice. But you have to acknowledge that this is a problem.
Good.
So we can do better in Sweden.
Okay, although I think it is challenging how to persuade the primary care doctors to use the questionnaires, yes. but yeah, definitely you have more in place than we have in Greece, because in primary care, for example, in Greece, we don't have any psychologists or other services in place, and it's not group set primary care facility most of the times. So Catalina, which are the challenges in Romania?
Well, the challenges I think are bigger than in Sweden, because you know, there are, I wouldn't say that Romanian GPs are not aware of the mental disorders of COPD patients. The problem is that because of the chronic underfunding of the primary care, the so-called primary care team is composed only by the GP and the nurse. So you can imagine that there is lack of time, lack of staff, the bureaucratic burden, and last but not least, the complexity of the COPD patient, who usually have several comorbidities that must be addressed. So I think sometimes it's more comfortable to refer the patient to the psychiatrist, which is possible and easy for me, for instance, because I work in the capital of the country, but thinking of my colleagues working in the rural area, this might be an issue.
Yeah. Yeah, but the referral system works. So if you want to refer to a psychologist and etc., it is possible easily, let's say.
I cannot refer the patient to the psychologist, but to the psychiatrist who will do the referral. And this is also a barrier, because when the patient hears that you intend to refer him to a psychiatrist, most of them become reluctant.
Yeah.
And that there are also some issues with the smoking cessation treatment, because there are some colleagues who think that treating anxiety and depression is difficult to do in the same time with smoking cessation treatment. Unfortunately, this is the case in some.
I will ask you more probably later on, because this is really interesting, and I think it's a problem for all of us, for all countries, how the colleagues receive that and how they think about it. So, Steph, what's the situation in the UK? Is it better, or?
I think in the UK, something between Björn and Catalina. It's unusual to have psychologists attached to practices. General practitioners generally work in groups, but not always. There are still occasionally single-handed GPs, but it's generally groups. There's a massive problem at the moment in the UK with understaffing in general practice, and a feeling of sort of concern about vacancies. So the whole system is very stretched. I'm sure it's the same in other countries. So there's a lot of unfilled posts, so people feeling under pressure. It's unusual to have a psychologist in the practice, occasionally, but not often. But what happened was, several years ago in the UK, to increase access to psychological services, they developed something called IAPT, Increasing Access to Psychological Services. And GPs can refer patients there. And in fact, patients can self-refer there as well. They're assessed over the telephone. There's often quite a long waiting list. And if they need treatment, they'll receive it, often over the phone, sometimes face to face. They didn't used to take people with long-term conditions. They used to just take primary anxiety and depression, sort of simple, basic mood disorders. But now they have a remit to look at long-term conditions. So in some places they will. But I think it's very, very unusual, because I work a lot with those services, that patients with COPD come through them, because it's still the norm that they're for sort of primary anxiety and depression, and people are not navigating that system. The other thing that really struck a bell with me was what Catalina said about psychiatrists, because in our practice in the UK and in our research, we have learned never to say to people that we think you should see a psychiatrist with COPD, because it's such a stigma, and they think, you think I'm mad. So we would always refer to psychologists. We wouldn't, we talk about sort of mood disorders, how your chest symptoms might be getting you down in your feelings, but we wouldn't say ever to somebody with anxiety, depression, you should see with COPD, you should see a psychiatrist straight away. That would be very unusual, because I think it would be exactly like Catalina has. It would be, they would perceive it in a, not in a very good way, and be put off by it. So we introduced psychology is a softer talking therapy way, and it's more acceptable.
Yeah, I must say here that in Greece is the same with Catalina. If the system would refer to psychiatrists and not to psychologists, because there aren't so many in hospitals or facilities. So it's a great stigma and challenge for the patients to accept that. But from what I get from your message, Steph, and just to make it clear, doctors, primary care doctors are aware of the mental health issues in COPD. But do you think they use questionnaires and they do the interventions that they are suggested?
No, I don't think they do. I think it's exactly like Björn said, that there's a tremendous focus on the spirometry, that they've had spirometry, that it's been diagnosed properly, and medication review, but there isn't the focus, because they don't get the financial reward for that, for assessing mood and referring people. to psychologists if they need it. So, and they are obviously, people care about people's exacerbations, that their lung health. There's a lot of concern about people going to A&E in emergencies and out of hours services when they get, it's the biggest cause of pressure on beds in hospitals, COPD in the winter. It causes a lot of anxiety in the health service. So there's a lot of focus on the exacerbations. I think there's a lot less focus on the mood and the whole patient.
And Cláudia, which are the challenges in Spain? And do you think the doctors are aware of these percentages that I gave, that they are very high? And do they use the questionnaires? Because we have many questionnaires in place.
So here in Portugal, it's a little bit of everything that we've been told. We have some psychologists, but they're not in our core group of GPs. We have like 1 or 2 psychologists for a big group of GPs. So it's hard to get an appointment with them. And they prioritize more other conditions like children or serious depression. Like Stet taught us, it's hard also to the patient with COPD to recognize their mental condition. It's a big effort that GPs do to make this holistic approach, because I think they recognize, they see how the patient suffers, how depression and anxiety impacts the evolution and the progression of COPD and the way they manage it. But on daily practice, they're more focused on spirometry, if they do good their inhaler, if other comorbidities like hypertension or sleep apnea, if all of them are controlled. Yeah. They don't use so much questionnaires in depression. They write it down in free text, like their faces, their mood, what family says about that, but not so many objective tools like questionnaires.
Okay, so how can we improve that in Portugal?
So I think the questionnaires are very good for countries like Portugal, because we are not too rich. We are based in a national health system that has to survive to all this crazy world that we are passing by and all the costs in life. So public health, it's very important. And a questionnaire, it's very easy, it's cheap. Most of them are quick. So we have to talk with colleagues and explain the impact that mental health has. I think they know already, but if they put that in a questionnaire, they can evaluate a long time how it goes. And it can be much, much better to manage this comorbidity in COPD. I think if we don't manage anxiety and depression, we can't manage all the rest of the symptoms, because they are not able to deal with their disease, and they can be strong to make their rehabilitation, to take their medications, and to look into the future. Okay. Mainly, and also to get our message, because they're not open to that. I think this is really the first step.
Thank you, Cláudia. So is by seeing that as a primary care physician serving in a rural area and also collaborating with an academic department here in Crete, in Greece, how is the situation in Greece? And what will you do differently? And if you would like to speak about the holistic approach a bit that we should take.
Thank you, Ioanna. In Greece, although there are national treatment guidelines for COPD in primary care, unfortunately, the clinical practice model is fragmented and ineffective. This is because attributable to the fact that there is no clear screening guidelines, when to screen, who patients to screen, or maybe screen high-risk patients. We have to face a lot of barriers regarding healthcare professionals, because in Greece, most GPs under-recognize emotional distress, or they believe that mental illnesses fall outside their scope of their clinical practice. Of course, there are time constraints. There is lack of interprofessional relationships or connection with the psychiatric department. Unfortunately, we don't have psychologists in the primary healthcare center. Fortunately, in the primary healthcare center that I work, we have every month psychiatric evaluation. The team comes from the hospital, so we have some kind of connection. But of course, I think the main problem is the lack of knowledge, because many GPs feel that they don't have the confidence or the knowledge to address mental illnesses in COPD patients. Of course, as all our colleagues said, there are patients' barriers like the stigma regarding mental illnesses, and many patients are reluctant to disclose any symptoms, or probably they under-recognize the symptoms, or they don't have the social support or accessibility to healthcare. So it's really important. But I also have to stress out that our system, our healthcare insurance, most of the times doesn't cover all the expenses for psychologists or maybe cognitive behavioral therapy. It's also worth noting to mention a study in a Greek population that stresses all the fears and all the anxiety COPD patients have, and also the dissatisfaction of the patients from the healthcare system. They feel that the healthcare system actually does not meet the requirements for these issues. So it's really important to implement some interventions to face all these challenges. It's not easy in Greece, I suppose in other countries as well, but we need more reinforcement, more patient-centered approach, a holistic approach to well-being, because most of the patients, the COPD patients, don't come to the practice and disclose such kind of symptoms. So we need to elicit these symptoms from them. And we need, of course, education, motivational interviewing techniques, and of course, more education.
Okay, thank you, Isolde. So in our desktop helper, we spoke about the breathing, thinking, functioning, vicious cycle, and the connections with breathlessness. So we said that when breathlessness is there, patients take deep breath. So this makes breathing inefficient. And if they have fears or misconceptions, the situation gets more complicated because this further escalates breathlessness. And people with COPD, they also are used to sit in a chair and then don't do a lot of exercise. So what we suggested is to try to break this vicious cycle and suggest people to start exercise more, for example, or to discuss more their mental health issues and fears and misconceptions in order to keep their body and mind more healthy. And most importantly, we said that we should let them focus, teach them to focus on breathing and relaxing the upper chest. So in order to break this cycle and improve breathlessness. So do you think, Isolde, for example, that people know that, our GPs, do you think that they will be happy to adapt this in their system, in their daily clinical practice? What do you think? Your personal view, of course.
I think that most of the GPs are not aware of this model, because this model, I wasn't aware of it. But I think this, I think
thanks for your honesty.
We of course know all the concepts, but we didn't combine them in these three vicious cycles. But I think this model is really important and it's really interesting, because it's a model that incorporates all. And if we target or focus in every vicious cycles, I think that every GP will have benefit of implementing this approach.
Okay. Steph, would you like to give your opinion on that? Because I know you use it in UK.
Yeah, it's very closely related to the CBT idea of the interrelatedness of symptoms, thoughts, feelings, and behaviors, which is one of the core aspects of cognitive behavioral therapy. I'm not sure, to be honest with you, GPs are very familiar with it, but a lot of the management of COPD patients in the UK, being a long-term condition, is actually done by practice nurses. And I think they would be probably more aware and more, especially if they've had some respiratory training. And obviously respiratory nurse specialists will be very, who may be working in the community, would be very, this sort of approach would be very familiar to them. But I think I'm not sure GPs would really recognize this necessarily, but I do think that there's generally people recognize the deconditioning that happens in patients with COPD, fear of exercising and inducing breathlessness, leading to less and less exercise, and that's obviously a key problem. I don't, to be honest with you, know in the UK if GPs are always very good at referring people to pulmonary rehabilitation. Shockingly, we know there's a lot of variation between practices, and certainly a few years ago, I met some practices where they never referred anybody. The GPs never referred anybody to pulmonary rehabilitation. So I think there's a lot to be done on sort of basic sort of education, and that to inspire confidence in people that there are positive things we can do for people with COPD.
I think just to add to your comment, I think it is, even if they don't know this vicious cycle or how to break that, I think it is important for primary care and or other healthcare allied professionals involved in primary care to teach the patient. So for me, it is really difficult to understand how we never speak about with the patient about the breathlessness, the way they breathe, the techniques on how to breathe better, the exercise also, or the fears. We don't spend a lot of time to discuss the fears and misconceptions of patients. And I see Cláudia is making some face movements.
Yes, because I think all of us feel that. Even I think our colleagues, they may not be aware formally, but I think they know that. And I think it's very hard in our appointments with so many patients and trying to recover a lot of more organic diseases that we lost in the past years with the pandemic situation, to have time to make a holistic approach to make COPD patients recognize they have low levels of self-compassion. It's important to break this and to let them talk, to make open questions, to make them express what they feel about their disease, about their symptoms, and then to manage those open questions with positive message, to reflect about that and to make a plan in a positive way. And this takes time, and this takes also a lot of knowledge about resources that you have around you, the local resources that the patients can use.
Mm-hmm.
And
so Cláudia, in continuation of what you are saying, so we are saying in our desktop helper and in the cases everywhere that motivational interview and the OARS models, or the open affirmation, reflective and summary, should be in our daily clinical practice. So do you want to say a few words about that?
Yes, that was a little bit what I was talking. The worst approach give us in order the steps that we should use with the COPD patient. And it's a little bit about this, about an holistic approach between mind and body, about what they have, the symptoms they have that are due to the COPD, and the impact on mental health, what they feel about their symptoms, about their limitation, about their future, because they know what will happen. And with an open question to let them feel, to make a connection with them, to feel that they can trust their GP, and with affirmations being positive and reflecting about what we felt about what they said, showing them that we understand the way they are in our appointment and the way they feel about the disease, and making in the end a small summary about what have been discussed and what the plan that should be made. I think it's quite important for the patient, for us, for our connection, and to build a way, and that we know where we are going and which are our goals and what we can do to reach them. And I think this is one of the main approaches to get to success with the COPD patient.
Thank you, Cláudia. So, Björn, would you like to tell us a bit about the questionnaires that can be used, and if it's worth spending more time or more resources to educate our colleagues in IPCRG about the questionnaires and how to use them? Are they easy? Which would you suggest, and what's your view?
I think that there are some problems with questionnaires. You must have them. And you must have them in your own language.
Yeah.
And you must be familiar with them. And I think in Sweden, GAD-7 is used.
Mm.
And also, and we have it in Swedish. And also in depression HUD. But they are both a bit long, so when you have an appointment, perhaps we need shorter questionnaires. We have the 2 questions in GAD-2, and in the desktop helper, we have 4 questions. And I don't know if they are translated to other language. Do you know that, Ioanna?
Yes, they are translated. I think the main problem is we propose in the desktop helper the simple WHO PHQ-4 and also the GAD-7 and 9, which are translated in the majority of the languages.
GAD-7 is very easy, but the other 4 questions, are they translated?
Yes, they are translated. The problem is, I think, and I would like a comment in that, is that the material is there, so most of them are translated and they are in place in order to identify either depressive symptoms or anxiety symptoms, but they are not used. So I rarely see a colleague with the questionnaires in their desks or in their computer. So I think we need a lot of efforts to improve that, and I suppose you will all agree with that. So
yes, and also in Sweden, you know, everything is in the computer, so you must have them there.
Yeah, that's what.
And also a part of the record. You know, in the record you can find cat and so things like that, but you also need to have these questionnaires in the record system.
Mm-hmm.
So it's easy to use.
Good.
And I think we can do a lot of promoting using short questionnaires, as you said, with the 4 questions, and also longer questionnaires like GAD-7. And now we use CAT. And 10 years ago, no one used CAT. So we can do things, and we can, changes can be made.
Yeah, I fully agree. I will interrupt you by saying that we have spent the last 10 years in persuading our primary care physicians to use health status or quality of life questionnaires in COPD like CAT, CCQ, and etc. So now we want to change the scene and persuade them to use more questionnaires.
Yes, add something, yes.
Which is challenging, but obviously by the high prevalence that we mentioned of 30% depression and 70% anxiety and the breathing, thinking, functioning model we presented, I think this is a clear need for more education and this to be built in the system, as you said, in the computer of the primary care physicians. So
I think one problem is if you listen to a lecture of COPD, many of the lectures are given by secondary care physicians, and they see COPD as a lung disease,
exactly.
and they don't see the whole patients. So if you go to chest physicians in the hospital, I don't think they use any questionnaires about anxiety or depression, do they? In UK? No.
Steph, do you think they use it in UK, the secondary tertiary care?
I don't think they do generally. Obviously, it must vary, but and I'm sure there are some, and I know and work with some fantastic secondary care physicians who really see the whole patient and who are absolutely superb and would be screening for anxiety and depression. That's definitely the case. There are some who don't. We had, in my last research study, we had a consultant, because out of politeness, we were screening patients for anxiety and depression, and out of politeness, we were copying in, with the patient's permission, their physicians, their GPs and their hospital consultants if we'd recruited them in secondary care. And one hospital consultant was very angry and wrote to me and said, I don't want to know this patient's got depressed. What am I supposed to do about it? I'm not a psychiatrist. And that's just a couple of years ago. And I was really shocked to that. So that's very much the case. But on the other hand, I wouldn't generalize. There are lots of fantastic secondary care consultants who are very aware of the whole patient.
But I think we all agree the main field of working with mental disorders and spotting, let's say, screening and identifies the primary care physician, because he is the one that will see the patient holistically. And also, you all remember the multimorbidity activity that we had, and it strongly connects with the mental health in COPD. I think this is the field for mainly primary care, and of course, it's open to everybody. Catalina, do you want to add something?
Yeah, I wanted to say that I mentioned before time as an enemy, but for our specialty, time could be also an ally, because we have this specific the continuity of care. So we see patients more often than the other specialists. So okay, maybe I don't have time now to complete the questionnaire with the patient, but I can make a notice somewhere to do it the next time he will be in my office. So yes, I think it's more a job for us.
And we also have the opportunity to see the patients more often. So, and in their environment, which I think it's very important. So to their houses, you know, with family, and spot more easily, let's say. So I think the comment you make is really important.
Yeah, and they are more open there.
Yes.
Because usually when they go to the specialist, the other specialist, they might be in an exacerbation, they are worried and somehow reluctant in bringing out other problems than the respiratory ones.
Okay, thank you, Catalina. So, Steph, I will ask you, in our desktop helper and in the cases, we spoke about the interventions to address breathlessness, and we said that cognitive behavioral therapy could have a value, and also mindfulness, mediation, relaxation techniques, and singing therapy could also be improved breathlessness, perhaps with acupuncture or pressure. Can you give us a comment on that, and mainly on CBT, that is the one that is mostly used, I would say?
Yes, there's evidence from systematic review, so good quality evidence that cognitive behavior therapy helpful in depression with COPD, and a bit less evidence for anxiety, but some evidence. So definitely that's the best evidence if you look at the formal research literature. I think there's a new type of therapy called acceptance and commitment therapy, which shows a lot of promise, and I think is maybe very helpful for COPD if it's delivered by trained practitioners, trained psychologists. Positive psychology, there's some evidence for that. Relaxation is good for patients and generally very well received. So I think there are quite a lot of things that we can offer people that can really help them. So I definitely would, it's important to recognize the problems and then refer them to people who can offer these sort of supports.
Okay, thank you. Cláudia, do they use these interventions in Portugal?
No, I think it's, well, it's much, not in this way. It's much a simple approach and not so organized. They use this when they have an approach with a complementary team. Maybe when they are on rehabilitation, they often have the support of a psychiatry and a psychologist, but not the majority of COPD patients that are managed in primary care, mainly because these kind of centers, there are a few and they can't get all the patients. I really agree with Professor Catalina that we have this issue of time that can be a barrier, but also an advantage to us. And I think this is a little bit of the beauty of being a GP. It's to learn and to be aware as we're passing by the years and we have more knowledge about respiratory diseases and which tools we should use. And I hope in a few years we are using this kind of approach with patients, because I feel we can have very good results and improve COPD patients' quality of life.
Thanks. So one other important point that I think it's worth discussing is the connection of smoking with mental health and COPD. And we know smoking cessation is the most important intervention for COPD, but I'm not sure our colleagues have realized that death, depression, and anxiety increases with smoking. And they have, I think, and probably many still think that the depression and anxiety, when a patient has a depression or anxiety, the smoking cessation will be difficult, and that the quitting increases anxiety and depression. And this is a common belief about our colleagues, and we also see it here. So they are reluctant to suggest smoking cessation because they have the strong fear that this will increase anxiety and depression. So Catalina, can I start with you? What would you suggest?
Well, what we need to know is that these patients definitely require special attention in the effort to quit smoking. because there is a vicious circle. You also talked about a vicious circle that has to be broken. You know, smoking leads to COPD, COPD to anxiety and depression, which both have a negative impact on cessation in these smokers. So what is the result? The result is a COPD patient with poorer health status, increased risk of exacerbations and emergency hospital admissions, and consequently higher risk of death. So we really need to advise and support them in quitting smoking, which is not easy because tobacco smokers with mental health problems tend to be more addicted to smoking. They smoke more cigarettes, they are more likely to relapse, and they require support for repeated quit attempts. And this is why I consider that our desktop helper is of big help, because it raises the awareness of our colleagues on these issues. So it's important to know them, because this way we can avoid frustration and to understand the difficulties these patients have, and the influence of these difficulties on their efforts to quit smoking. I mean, in other words, we have to be aware that most of the time it is not a question about them not understanding the risks, but as we know, overcoming barriers. You know, breaking a long life pattern is difficult. It is never the right time to quit smoking. Previous plans to stop, which have often lead to no results, etc. So this is why we should be prepared to offer smoking cessation using interventions that were proved to be effective. Just to summarize, it is important to keep in mind that the evidence is strong to suggest that smoking cessation is a key intervention for smokers with COPD and should be a core element in long-term management of these patients. We should ask tobacco use at every clinical contact. We should advise about effective ways to quit and act according to the patient response. So use the very brief advice. As our colleagues said before, don't be judgmental. Encourage the patient every step. Reassure the patient that contrary to popular belief, quitting reduces anxiety and depression. Remember that smoking cessation may be more effective when counseling and pharmacological treatments are combined, and that it is important, adding medications and management strategies for mood disorders to a standard program of smoking cessation may achieve better long-term quit rates.
Yeah, thank you, Catalina. I think at this point I would like also to mention that IPCRG has the resources for all that. So we have material on very brief advice and the desktop helper, and also the guidance on smoking cessation published a few years ago. So for the colleagues that they would like to learn more, let's say, about smoking cessation, the resources are there. But I think the most important message is that we have to train our colleagues also that quitting reduces also anxiety and depression. So in order to be able to change this view of our colleagues, and Isolde, do you agree with that? Do you have a comment?
I totally agree, and I believe that we all have time constraints in our practice, but implementing the very brief advice really helps. And I think that sometimes patients are surprised that you have the time, 1 or 2 minutes, to deal with this problem. And most of them are willing to participate in a follow-up program. But of course, the most important is the follow-up of the patients, and the primary care environment is the ideal setting for that.
Thank you. And Steph, how can we change that view of the doctors that they are reluctant to let's say, to deal with patients that are smokers because they believe if smoking cessation occurs, then depression and anxiety will get worse?
I actually think this sort of session that you're arranging here, this educational session, is very important because it gives people confidence when they hear peers talking about these things. I think there is certainly in the UK, a very strong drive for smoking cessation and to support smoking cessation in primary care. I thought everything that Catalina said was superb. I'm a very strong believer in very brief advice because it's very evidence-based. And never shutting the door. If people say, I'm really not interested, or I always say, that's absolutely fine, but I'm always here. If you want to change your mind, if you'd like to come back and talk about smoking, if you want to raise it again. So never sort of being very open and just being there for the patient. They get the message, I think. I think it is something that's being done certainly in the UK, better and better in primary care. I am a little bit worried about the pandemic because that has disrupted patterns of primary care, and it will be interesting to see what's happened to smoking over that period.
Thanks. So, and the last thing that we discussed in our desktop helper is about pharmacological interventions, where I don't think we should spend a lot of time because SSRIs is the main answer to depression and anxiety according to evidence. So I think the non-pharmacologicals are of more interest for primary care, which we have discussed a lot. And before closing this meeting, I would like, if possible, just 3 messages, what we should do, 3 points for from all of you, or what will be your main interest to see in the future getting improved, let's say, in primary care. And just to say about that, we didn't deal with the severe mental illness, because this will be another initiative from IPCRG in the future. Your 3 main outcomes of this discussion, and what would you like to see different in the future?
I think first of all, the first thing is that we need to recognize that mental health is could be a problem for the COPD patients. So we have to see that, to recognize it. And I think also we should start using questionnaires. And on smoking cessation, once again, it's so important.
Okay. Thank you. Just to say, no need to say 3 more, just to say for the rest of the speakers, just to say what you think is the most important, because probably Björn covered everything with these 3 bullets. Okay, Catalina, you're muted.
Okay, so I think we should help our colleagues to find a way to integrate the screening for mental disorders in COPD patients. And I think, and I believe in the computer software, because if it is there, I'll remember. Then we also have to support our colleagues in finding time, make a plan, learn a structured approach, being proactive and acting consistent, and to deal with the frustration in front of relapses, which I think is important. The third point is that I really hope to find soon the time, because I know I will find it, to translate in Romanian the desktop helper so that we can integrate it in the computer software I was telling about. Thank you so much.
Fantastic. And Steph, a comment?
Thank you. I hear what everybody's been saying about questionnaires, but in the UK, the 2 questionnaires for depression have really made a difference to my practice. And so even if you don't use the questionnaires, you can still ask if people have been, in the last 2 weeks, if they've been feeling nervous, anxious, or on edge, or not being able to stop or control worrying. And those 2 questions are really good at picking up people with anxiety. So I'm sure we can remember our 2 questions, and then there's 2 questions for depression as well, of course.
You mean the WHO 2 questions? Yes.
The GAD 2 questions,
yeah.
yes. Yeah, I think there's, to me, those are really useful things too, and they don't take very long, and then can help open up conversations. So listen to patients when they try and bring something up, which they often do, like trying to talk about their feelings. Don't shut it down, and think about using those 2 screening questions as part of your assessment when you're seeing someone with COPD.
Thank you. Cláudia.
Well, I think the main ideas have been discussed. My comment is that I'm very happy that we have this opportunity to talk about COPD patients and mental health and the impact of anxiety and depression on these patients, and how we should prepare ourselves and our appointments in these patients for being organized and manage our time to make this kind of approach, our ORS assessment, our questionnaires, and also not forgetting all the rest that we should do about the pharmacology therapy also. So I think our other thing that we talked here is working in team with different skills could help these patients. So finding in our places the resources and the way of the patient getting them, it's also a big challenge. I think this is a way that we are doing, and I think and I hope that this desktop helper that we have done and this discussion can help that way that we are doing all together, can help us and our colleagues also to improve mental health in COPD patients.
Thanks, Cláudia. And a last comment from you, Isolde.
I think that at first, the initial clinical evaluation of COPD patients is really important. And I think that all patients should be offered questionnaires because they are really helpful at imitating conversation and help patients disclose symptoms that are related to mental illnesses. Of course, follow-up is really important to reassess and maybe offer treatment to these patients. And of course, smoking cessation should be offered in every advice, ask or act in every clinical visit, regardless of the patient's views at the first visit. Of course, we don't have enough resources, but I think that with the appropriate education, even a nurse can help us with more specialized treatments. Of course, it needs time and more resources, and education like this and the desktop helpers are really helpful and the first step in this process and this management of these patients.
So I would like to thank you all for joining us in this. I hope it's nice for our audience to hear, and we don't spend their time, but I think it was a very nice discussion. And I would like to say that I'm grateful to IPCRG because those are topics that are rarely discussed, and they are very important for our patients because the main idea of IPCRG is to deal with primary care and also patients with respiratory diseases by seeing the patient holistically. And all this material is, I like the fact that the desktop helpers are connected. So we have the multimorbidity, the smoking cessation, the mental health, so they are all connected towards the benefit of the patient. And I would like to thank Sean Williams and Nicola Connor for their help, and many others that I don't want to say all of them because I will forget many. And thank you all for joining me in this session today. I think it was really nice and also helped me understand how other countries work as well.
Thank you.
Thank you very much. Lovely talking to you all and meeting you all.
Thank you.
Thank
Thank
you.
you. Bye.